Welcome to the Healthy Living Series, a series of talks brought to you by the University of Alaska's Summer Sessions and Lifelong Learning in partnership with Foundation Health Partners. My name is Joan Braddock, and I will be your host for this summer series. The Healthy Living Series, in its 8th season, has been a lecture series held in person in past summers. The COVID-19 pandemic and social distancing guidelines required that we rethink the format for the series this summer. We are delighted that KUAC has agreed to support the new format for the series as a weekly TV broadcast. We are also grateful to our speakers who were willing to be incredibly flexible in adjusting to this new format, and we appreciate the time they are donating to help us all live a healthier life. Before I introduce tonight's speaker, I want to let you know that you will be able to view the talks online after they have been aired by going to the UAF Summer Sessions' website at uaf.edu/summer/events. I am now delighted to introduce our speaker for this evening, Dr. Peter Dillon. Dr. Dillon joined the Tanana Valley Clinic First Care team in October 2013, and he now serves as the Director for TVC First Care and Addiction Medicine. Dr. Dillon came to TVC from the U.S. Army, serving at Fort Wainwright for the preceding 3 years. Dr. Dillon continues to serve as a Lieutenant Colonel in the Army Reserves and has deployed multiple times, supporting special operations and conventional combat and contingency missions around the world. Dr. Dillon began his education at the Ohio State University, where he graduated with a Bachelor of Science in Nutrition. From there, he attended the Georgetown University School of Medicine, where he completed a Doctorate of Medicine in 2007. After concluding his doctorate studies, he went on to complete his residency in family medicine. Dr. Dillon specializes in family medicine, but also has interest in addiction medicine, wilderness medicine, pre-hospital medicine, and combat and tactical medicine. On a more personal note, Dr. Dillon enjoys hiking, fishing, and exploring Alaska with his family. Tonight, Dr. Dillon will be talking about the very important issue of another pandemic, substance abuse, in his talk entitled Use Abuse Disorder, describing substance use disorder.
So, from that, the folks here at FMH and with a lot of the group of physicians who work in the TVC addiction medicine program, we developed an opioid education sheet. And this is something that's available statewide. It was adopted by the state, but Fairbanks, we get to take some credit for this. This was developed here. And it educates people about the risks of opiate pain medications. And again, it talks to some of the things I've already mentioned, that most people whose first experience with opiates was a legal and licit prescription. For a certain percentage of people, that will end in illicit and substance use disorder diagnosis. In as little as 3 days, your brain chemistry begins to adapt and change to account for those opiates. So the idea that, oh, I just got my 10 days worth of pain pills, which was a routine, and I was guilty of this just as much as anybody. You have a broken arm? Yeah, here's 10 days worth of pain pills. Not a thought, no big deal. And that was just the way I was educated. That's not the way we do it anymore. These come with serious risks, and it's a serious conversation that you should have with your doctor. Let's say you end up with that 10 days worth of pain pills. Oh, well, I only took 3 days worth, but I'm going to stash this in my medicine cabinet for the next time or when I need it. Or I'm going to put it in my hunting backpack because I'm going to go out to moose camping just in case something happens to me. And that's fine. A lot of people have said that to me. However, a number of people's first exposure, particularly when you talk about early and mid-teens, their first exposure with opiates wasn't a prescription from a doctor. It was in mom and dad's medicine cabinet. It was rifling through dad's hunting backpack. Or when grandma died from her end-of-life cancer care, she had a bunch of pain pills laying around. A number of people's first exposure comes from that route. Even veterinary care is another way that people, oh, my dog gets tramadol, and I took my dog's tramadol. I mean, these are very serious ways that people ultimately, what seems innocuous, what seems like, oh, no big deal, I'll just give you a script so you can hang on to it in case you need it, can lead to ultimately a potentially life-threatening condition if the wrong person gets a hold of that medication. So again, something to consider, part of why we have this education sheet, and again, a good platform to have an informed conversation with your doctor. I also wanted to go over a little quick thing that we utilize. It's now nationally standardized, but Alaska has a prescription drug monitoring program. So again, another way you can have an informed discussion with your doctor is that everybody who dispenses scheduled either 2 through 4 substances, which is the way the DEA categorizes how likely is this substance to be misused or abused, we can now keep track of that. And that's a good way ahead for identifying people who are at risk. Who is using more than one sedating substance? Because let's say you get a pain prescription from me at First Care, and then you get a sedating sleep aid from your doctor, and then you also get something else after you have your surgical procedure, for example, from another doctor. And if none of us are knowing what the other doctor is prescribing, that's that recipe where somebody takes their pills that have been prescribed by a doctor, so they think they're following the instructions, and potentially have an impact where they don't wake up. So again, it's very useful. And it's a very important tool that we have as prescribers, as pharmacists dispensing medicine in our community. It's a way to keep track of who's getting what, and is that creating a situation for risk. So now we're going to talk about how people got to having a risk scenario for substance use disorder. What do we do about it? So what we utilize in the TVC addiction medicine program is a medication-assisted treatment approach. And what that means, we use medicines that are approved by the FDA, regulated by the DEA, to treat substance use disorder. Specifically for opiate use disorder, we use a medicine called buprenorphine, and we use a medicine called naltrexone. And we have to do that in combination with behavioral health treatment. Again, the behavioral health disease is a big component and predisposes people to use substances. Again, they are using those substances to treat their behavioral health disease. So you can't do one without the other terribly successfully. Some people don't need medicine and only need counseling. Some people only need medicine, don't need counseling. That's a pretty small percentage. Your best chance for successful treatment, and we'll talk a little bit about what do we define as successful treatment, but people who are engaged with medicine and engaged with counseling stand a better chance of a meaningful recovery than people who do one or the other. So what that means is, and the way I kind of articulate that to patients is, the medicines we give come in standard doses. You're going to take 8 milligrams of buprenorphine, you're going to take 50 milligrams of naltrexone. That's not individualized to that patient's experience. The counseling addresses what happened to you when you were younger. How did you end up in this place? What did you do or what did you experience that led you down, and why did you start using substances in the first place? That is individualized. There is no way I can take a drop of somebody's blood and say, oh, you need this dose of this medicine and you need this type of counseling. It doesn't work that way. We use standard doses that we think keep people safe, that don't cause side effects, and then we rely heavily on that individualized, customized treatment that comes in the form of good behavioral health care. Now, Fairbanks is a tough place to get good behavioral health care. We do not have a lot of access to mental health treatment in this state, but specifically Fairbanks. So that's a real challenge. And again, we utilize every one of our assets that we have. TVC has just recently started utilizing an integrated behavioral health approach. We have 2 psychologists, we have a licensed professional addiction counselor, we have a psychiatrist who should be here by the end of the summer, which is really exciting. But we're starting to get those pieces in place. But right now, there are not as many behavioral health practitioners as there is a need for behavioral health care. It sure would be nice if we were faced with a problem of too many behavioral health care providers and not too many Starbucks. So, but for now, we're doing the best we can, and that can come in every shape or form. So, particularly when it comes to a community that doesn't have a ton of resources, that good behavioral health therapy can come in the form of your faith-based clergy approach. And so if you engage with your church group and that works for you, perfect. That can be Narcotics Anonymous, Alcoholics Anonymous. That can be a licensed counselor. That can be what's called a peer support. So somebody who's been down the road of recovery and has made progress in their own recovery, and their stepwise approach to how do you get through this is because they've walked that road. There are a number of ways to do that. Our way is not the only way, and certainly if there were a recipe or a cookie cutter approach, we would use it. But again, back to this, it has to be an individualized process. So, medication-assisted treatment. We use buprenorphine, as I mentioned, and naltrexone. Now, the other FDA-approved medication for this is called methadone, and I'm going to talk a little bit about that. So that has to be done in a federally funded treatment program. So we have the Interior Medication-Assisted Therapy, or IMAT, here in Fairbanks, and that's located at the Interior AIDS Association. That's where you can use methadone, and that is very tightly regulated. Actually, one of the other docs who works in our addiction program also supervises as the medical director for that program. So everybody's got a different role to play. But a full opiate agonist, basically what this means is, in place of heroin, we're giving you methadone. And methadone saturates the mu receptor, but it's long-acting, meaning it's pretty hard to get high. It sticks around a long time, so people aren't constantly getting a craving to go use it. It's not perfect. People can overdose on methadone. You can become addicted to methadone. And what I mean by that is you can try and obtain methadone illegally, because methadone is also a pain medicine. So there are people with prescriptions for methadone. But we don't utilize that at TVC. Again, that has to be regulated in a federally supervised program. And like I said, in our community, that's done out of Interior AIDS or at the IMAP. We use buprenorphine. And buprenorphine is a partial agonist. And what I describe that as is like having a dimmer switch applied to your light switch. So again, full agonist, it's on, it's off. Buprenorphine is kind of on, kind of off. And then the convenient thing about buprenorphine is it has a very long half-life. And what that means is once it's bound to the receptor, it actually binds more tightly than heroin, and it sticks around much longer than another opiate. And what that means, again, without trying to bore you too much onto the pharmacology and the chemistry there, is that people can be very functional. They don't get high. They are able to engage in treatment effectively. They don't have cravings, generally. They aren't experiencing withdrawals or getting dope sick, as most of my patients describe it. And so they are able to engage in a much more controlled way than what many people refer to as the chase. You may have heard the term chasing the dragon. But again, what happens is these folks who are suffering from substance use disorder get to a place where the only way they can feel normal is to use. They feel sick otherwise. And so they are constantly seeking out where can they get more heroin or more opiates to feel normal. And again, that dope sickness, people will do any number of things to maintain their continued use. And that means illegal activities, unscrupulous, you name it, and everything in between. And oftentimes, when people end up in the law enforcement realm, it's their behaviors are trying to continue to avoid that dope sick. And again, the way buprenorphine works is it takes that away without causing any of those other side effects. The other thing that is interesting about the partial agonist is it doesn't cause the respiratory depression. And what that means is if there's buprenorphine in a community, because I will tell you, every one of my patients has taken Suboxone that they have bought off the streets. They have taken Suboxone that I may have prescribed for somebody else that was then sold on a secondary market. But if Suboxone exists in a community, there are fewer opioid overdose deaths. And again, more people on Suboxone, it's not impossible. Anything's possible in medicine, but it is really hard to overdose when someone is taking buprenorphine. Again, Suboxone, buprenorphine binds more tightly at the receptor than heroin, and it lasts longer than heroin. So like I said, it helps people avoid that overdose death. So the last thing I'll talk about is naltrexone. It's actually an antagonist, so it blocks opiates. So it binds to the same receptor, and then nothing else can bind there. Okay, so this is like taking the light switch out. You're never turning that light switch back on, if we use that same analogy. Interestingly, with naltrexone, there also is some hormonal regulation that gets disrupted, and so it's very useful in treating alcohol use disorder, and so that's one of the reasons we utilize it. And again, it's a pretty poorly understood mechanism, but people want to drink less. Essentially, the way I describe it to patients is you remove the secondary reward that you get when you drink. Again, a very poorly understood mechanism as it impacts the brain, but it works, and therefore we use it. So last drug I'll talk about as far as our category is the acute overdose treatment, and this is naloxone, or Narcan is what this is called. It's gotten a lot of notoriety in that this is what's keeping people alive. Part of the reason that the life expectancy didn't plummet as much or as fast when I talked about our overall life expectancy decreasing was availability of Narcan kits became something that you could have with first responders, so a lot of law enforcement folks are carrying this. A lot of places that have an AED on the wall will also have a Narcan kit. Again, that's how much this opiate crisis has impacted even our places of business. You can get it over the counter. You don't need a prescription. Your doctor certainly can prescribe it. People who use opiate medications chronically, back to that opiate education sheet, you should talk to your doctor. If grandma has a lot of pain medicine around because she's being treated for, let's say, end-of-life disease with cancer, you should also have a Narcan kit on hand. Again, these are things that are very easy to administer. The most common one that you see is a nasal inhaler, so you just stick this up somebody's nose and squeeze. There are injectable versions that you can either give intravenously or intramuscularly. Again, you can actually get it free at a lot of places. The police and fire departments have it. Public health here in town has it. Again, you can go to Walmart Pharmacy and get it. You can go downstairs to Alaska Family Pharmacy and get it here at TVC. And then the last thing I'll talk about is it's actually added to buprenorphine to prevent misuse of buprenorphine. So again, I told you guys buprenorphine is a partial agonist. Generally, and we'll talk about how we do it here with these folks, you can get buprenorphine prescribed to you, but if you decided to misuse buprenorphine, because it's designed to go under your tongue, but if you decided to melt it, draw it up in a syringe, and inject it by itself, you actually can still achieve some dissociation, some high from that. If you add naloxone to that, what happens is when you inject buprenorphine, the naloxone is preferentially bound at the receptor because, again, it works instantly, right? So you'll actually prevent someone from misusing their Suboxone by injecting Suboxone. They'll actually go into withdrawals almost immediately, and they're going to have a pretty bad day. So it is added as a deterrent so that people don't misuse Suboxone, okay? Here I list out some of those folks that can offer treatment. I mentioned IMAT. They can do daily dosing for methadone is generally how that's done. They can also dose buprenorphine like we use. TVC's addiction program, we do consults at FMH. We do services for teens. As young as 13 is how young we've taken care of. We have a pretty big capacity. We can manage 600 patients right now. There's acute detox, which is offered through Gateway to Recovery, and that's another place that you can have buprenorphine therapy initiated as part of an opiate detox and an alcohol detox program. So these are the places in town. There's a few others here and there. They have less capacity. So again, if you think that you have concerns, like I said, we think we do a pretty good job at TVC, and certainly have the ability to care for a number of patients. So here, back to what is Suboxone. So it's a sublingual medication. It comes in a film and a tablet. Place it under your tongue. We also actually have a subcutaneous medication now, so it's a monthly injectable. That's pretty exciting because it takes a lot of patience because, and I didn't really talk about this when we were defining addiction and the tolerance, but some of addiction is actually a habit, right? And so the easiest place that I find talking about that is actually with tobacco. So the habit, I have a cigarette after I have every meal, or I have a cigarette when I drive, right? That's that habit. Now, certainly nicotine is a very impressive psychoactive substance, and we're not going to talk a ton about it here, but some of it is I'm putting that in my mouth, right? And again, Suboxone's no different. So you get someone who's stable, they're making progress with their treatment from their behavioral health standpoint, but they can't really break that habit. And so if you can inject the substance once a month, now they can begin to really make progress on that habit side of things. And again, habit is a word that's kind of frowned upon in the addiction medicine realm because again, it's not truly a compulsion, and it's not really only limited to they have to do this. There is a secondary reward that is happening, and again, some of that's emotional, some of that's conditioned. Again, these are hard things to measure objectively, but certainly there are people who can identify with the fact that they are still relying on a substance. And what that means is they are emotionally relying on that. When I get stressed out, I want to put that under my tongue, for example. And so again, that injectable version of that is very useful. So, you put this under your tongue, 5 to 20 minutes. I will tell you, very few people actually sit there for 20 minutes, but you're not supposed to talk or eat or drink anything after you do this. And so this can be a barrier. And so some people don't like this because they got to sit there and be quiet for 20 minutes. Let's say you work in sales, for example, and you got to take your medicine in the middle of your workday. That could potentially be a barrier. Again, it's nice that we now have this injectable version of that for some patients. But that is how you are supposed to take this medicine. And again, I talked a little bit about how you can misuse the medicine, but we do a pretty good job to prevent that. I talked a little bit about the receptors. I promise I won't bore you too much, but essentially this is a graphic of what does a partial agonist look like. So again, the green ball there is heroin, for example, and it has a perfect fit into the receptor and it binds tightly. Those little orange balls there on the bottom half of this picture, they are a partial agonist, meaning that's an imperfect fit. So the key kind of goes in, but it doesn't turn the lock, but it prevents the heroin from binding. And again, it's a long-acting process, so it lasts 24 hours. Some of the complications that we run into with this, so it's not for everybody. You can actually create precipitated withdrawal. So we go back to that slide. If you think about it, the buprenorphine will kick the heroin right off that receptor. And so you can actually put someone in withdrawals if they take this Suboxone while they have actively used an opiate recently. So again, you can take somebody, it's not quite as rapid as if you administered Narcan, but it's pretty close. And so to help with some of this, as people engage in treatment, we do use some medicines, particularly if a patient is in the hospital, for example. We will help support them through that process. We don't do a medically supervised detox at Tanana Valley Clinic, but we can do that at FMH. Again, here's that precipitated withdrawal that I mentioned. Like I said, you kick your heroin off the receptor and you make somebody pretty uncomfortable pretty quickly. But that's about the biggest risk of using Suboxone to treat substance use disorders, specifically opiate use disorder, is that you're going to make somebody uncomfortable. Overall, like I mentioned, as you look at the risk from a community-based standpoint, you can keep people alive. Fewer people die when Suboxone is available in a community. So that goes back to, and again, I touched a little bit on the trauma-informed care, but one of the things that we focus on as well at Tanana Valley Clinic is what's called the harm reduction model. So again, we're not looking that, and we don't define successful treatment as I've never touched heroin again. We don't define successful treatment as I never drank another drop of alcohol. those are great stories, and certainly people do very well. And if that's the life that they're able to achieve, that's fantastic. And that's certainly a goal that we set for some of our patients. But some patients, truly, we're just going to reduce the amount of harm they do to themselves. And that can come in the form of, I no longer inject drugs, I only smoke them. Again, when you talk about injection drug use, it comes with increased risks of HIV, hepatitis C. There are a number of other medical complications that can become very problematic for a lot of patients. So again, if we make that little change, again, is that ideal? And certainly would Nancy Reagan in her red dress tell me that we've won the war on drugs? I don't think so. But again, when you talk about community focused, that is one less person spreading HIV. That's one less person sharing dirty needles with hepatitis C. So ultimately, from the harm reduction standpoint, we've made progress there. It's not ideal, and maybe they do need a better and higher level of care than what we can provide at Tanana Valley Clinic. But again, we're still making progress. What it also does is we're no longer playing the high school guidance counselor, like, we got you. Again, what we're fostering is an environment where patients can come and tell us, yeah, I slipped up, or I had this life stressor. My dog died, for example, is one that I've heard before, and all of a sudden the only recourse that I could use or think of was to go buy a bottle of vodka. Or I broke up with my significant other. The only thing I could think of was to go find heroin. Again, most of the time these are a pattern of behaviors in response to life stressors, behavioral health disease, exacerbations, and that learned process of I don't like the way I feel, so what I'm going to do is go use drugs. Again, this is how we help address that. And so we can say, oh, you're suffering from an acute exacerbation of your depression. Let's get you better help for your depression so you continue to have healthy outlets and better behaviors, less destructive behaviors as far as what you do when you're faced with those stressors. Because I tell all patients when they come into our program, you're still gonna have bad days. Not every day is gonna be sunshine and rainbows. And what are you gonna do when you have that bad day at work? What are you gonna do when you lose your job or you're fighting with your spouse? Is your recourse going to be, I'm going to go get drugs? Or is your recourse going to be, I'm going to go through some of the new ways I can address my stress in a constructive way? Does that mean I start exercising? Sure. Does that mean I read the Bible? Sure. Again, whatever works for those individuals, but it's a strategy, and it can be everything from mindfulness to guided imagery. Again, that's where that individualized and tailored behavioral health treatment becomes so important as we talk about what does long-term recovery look like. And the other piece that we focus on with trauma or with harm reduction model, and it does play into the trauma-informed care, is abstinence-based programs. Again, when they work for patients, I'm not here to say that they're not successful, because they're great, but these are folks who are already dealing with barriers to their health care. They've already been treated poorly by the healthcare system. So if you come back and say, we got you, you use meth, you're out of our program, well, where are they going to go? They're going to go back to using substances. They're going to go back to injecting drugs. So again, while we don't sit here and say that you can continue to use substances and be successful in our program, what it does is it allows us to say, hey, you get to own this substance use disorder. It's part of you, and it's going to be here. It's a chronic disease. So if you can have the ownership of that process, then you can start to make the changes that you need to make in order to get the kind of care that you need. And so again, that's part of why we use this approach. Again, not perfect and certainly doesn't work for everybody, but it's a way that we have found to keep our patients engaged in our treatment. So I will put a plug in about what we do here, just because that's what I know, and I am very passionate about this program. Foundation Health Partners and the Foundation board has been very supportive of this process. So they have given us lots of resources to address this need in our community. We've been offering outpatient services since 2010. We started to offer services in FMH in 2017. Most of that has been focused with our behavioral health population, so the folks who are getting treatment on the 4th floor at FMH, as well as another large percentage of our population is pregnant patients in the Women's Center. So we offer services at peripartum or at the time of delivery. We currently have 3 full-time nurse case managers. I can't say enough good things about them. They are all amazing. They work tirelessly, and they deal with everything from how do I get the patient to be able to afford a cell phone, to working through the bus routes to get them to and from their appointment, countless hours spent with the insurance companies to make sure that we can get medicine paid for. Because that is another thing that I should touch on, is these medicines aren't cheap. To use Suboxone, and if you wanted to take it 3 times a day and pay cash for it, that's a $400 a month medication, and that's with the generic. If you're using the brand name, and up until 2017 it was only available as a brand name medication, it would have been $1,300 for some patients monthly. The injectable drug that I talked about, where we can inject buprenorphine, that's an $1,800 a month medicine. Now, when you face that versus how much does it cost for someone to get admitted to FMH with their complication from their drug use, again, much less expensive. And that's why state and government payers all will pay, so Medicaid and Medicare. All the commercial insurances will pay. And again, if you have the means, this is why parents will spend countless thousands of dollars for their kids, or spouses will spend all the money it takes, right? Again, you can't put a price tag on that recovery. But ultimately, it is important. And again, one of the things I didn't put it in a slide, but did want to touch on that there is an importance there, that this does have a cost. And we work tirelessly, and I would love to just have a blank check to say anybody who needs Suboxone, we can give it to you for free. But at the same time, this is something that we work tirelessly towards and get to achieve that meaningful recovery. Because again, recovery is much less expensive than continued use, no matter how you slice that. So. We now have that full-time addiction therapist that I mentioned. We have the resources of our behavioral health providers here at TBC. We have a full-time registration staff person who coordinates all the follow-up appointments and all the additional lab tests and things that go with it. 6 docs, family docs, emergency docs, and not to suggest that we do anything dramatically better or different. One of the unique things about our program is we do address the comorbid health disease. So when people have HIV or they have hepatitis C, we arrange for that treatment. We coordinate those care. If you have hypertension and you've got opiate use disorder, we get you plugged in so we can manage your blood pressure. Again, that's sort of the whole picture approach that we've taken. And while it is not unique, again, we believe that it's the best approach and most successful way we can treat our patients. I mentioned this in one of the other previous slides, but we can take care of 600 people. We're not there yet. There's probably that need in our community. But again, right now, I will say with the SARS-CoV-2, much like barriers to getting your regular healthcare have happened, and for the first section of our response to the coronavirus, everybody, myself included, said, hey, stay home. If you don't think you need to be at the doctor, don't come to the doctor. Well, that's okay if we're talking about a cold. That's not okay if we're talking about opiate use disorder. And so we are a little bit lower. We have had some patients, and whether it's because of the social isolation or the anxiety or their depression getting worse, we've lost a few patients to our follow-up. And again, some of that has to do with some changes that were made in the criminal justice system as a result of the coronavirus response. Some of it is our own doing. We went to telehealth-based appointments for a lot of our folks, so we're seeing them on the computer. Again, not a bad way to approach what we do, but not the same as coming into the office and having a face-to-face conversation. So again, we actively manage 140 patients right now. We have probably another 80, 85 that we're aware of their care. They're either successfully completed with our care, or more often, they are not quite at the place where they're ready to engage with a complete recovery program. And so that we'll see them once, they'll leave for a few months, we'll see them again. And that's not an uncommon approach to how we eventually get to a place of more meaningful, engaged recovery. We've diagnosed over 30 new cases of hepatitis C in the community. Again, once we diagnose it, we get it plugged in for treatment with those patients. So again, those are patients who are no longer spreading hepatitis C around the community. Right now, we take care of about 30 alcohol use disorder patients. Again, there are other resources in the community that do a great job with that. So not that we can't do it, we just don't have quite the same volume. And also, we are one of the more unique treatment programs for opiate use disorder, so we just spend a lot more time with that. And again, as I kind of mentioned, that the OB cases are part of what got us going into the hospital in the first place. And so that is a big part of what we do. And again, working very closely with our pediatricians, our pediatric hospitalist group at FMH, as well as our outpatient pediatricians. So we coordinate that care both before delivery and after delivery so we can take care of mom and baby as best as possible. So I will touch a little bit on this. Folks that we take care of, generally, they've been using opiates for 12 months or more. They have some addiction behaviors, so whether that's illegal substances. And the reason I kind of talk about that is that's the folks who come to us through the court system. So one of the ways we engage with treatment with folks is they have been convicted, and one of their ways and recourses for getting treatment is part of their sentencing or part of their probation may be to engage in treatment with us. Folks who use more than one drug. So if you are somebody who uses methamphetamine, uses heroin, uses other substances, generally buprenorphine, while it's only FDA approved for use of opiate use disorder, the way I always kind of frame it is the guy who sells you heroin is also the guy who's going to sell you meth. So if you stop using heroin, oftentimes you use less meth. And again, while it's not a direct treatment for methamphetamine use disorder, again, we do see reduced rates of methamphetamine use because, again, you're not going to see the same folks, you're not buying the same drugs, and that is kind of the way that we approach this. And again, there's no FDA-approved treatment for stimulant use disorders, whether it's cocaine or amphetamine, methamphetamine, but we do see some success when we have patients engaged with our treatment program. And ultimately, what you utilize to treat stimulant use disorder is behavioral health treatment, and because we get patients engaged with that as well, we do see success. So we will treat any pregnant patient. Again, we have a very low threshold to engage because, again, when we view that, we're not just treating the patient, we're treating the baby. And so ultimately the stakes are a little bit higher, and we really work very closely, as I mentioned, with our folks on the OB side in the hospital as well as the pediatricians. So that is a priority, and that patient population, which is incredibly vulnerable, we work very closely to help get them the care they need. So again, as I mentioned, the category of medications, benzodiazepines. So as I mentioned, it's pretty hard to overdose on buprenorphine. It's hard to have a bad outcome with buprenorphine. That is as long as you're not using other sedating medications. So the stakes go up dramatically higher, and the risks of overdose go up significantly when you have buprenorphine and Ativan, for example, is one of the more common benzodiazepines that's prescribed and misused. So, and then the last thing is folks who are prescribed really, really high doses of pain medication. They are really challenging to manage with buprenorphine only. Molecule for molecule, buprenorphine does actually help with pain. It's 40 times more potent than morphine for managing pain. But for really high dose pain prescription users, buprenorphine oftentimes is not an adequate pain control mechanism. Now, some of that, again, goes to the comorbid behavioral health disease or things like that, but generally speaking, folks who use really high doses of opiates in a prescription setting, they struggle when you transition them to buprenorphine. We still talk to them, we still work closely with their primary prescriber of their pain medication, and we will talk to anybody about how they can use less opiates. Again, buprenorphine may be a strategy, but it's certainly the evidence points and the scientific studies point to that being a harder patient population to treat. So one of the questions I get a lot is, well, what does it look like? What's recovery look like? What does that patient do? How do they engage? Again, we use that harm reduction. So again, does recovery mean I just don't inject anymore and I only smoke? Okay, probably not the ideal endpoint that we want, but again, it's progress. how many more days are they engaged with sobriety? How many more days are they engaged with their job? These are measures of success. How many more months are they engaged in our program? One of the points I want to emphasize is that if you integrate behavioral health, your outcomes are better. But ultimately, you want these folks to be reintegrated into the healthcare system. You want them to get their routine healthcare screenings. You want them to get routine well woman care. You want them to get their mammogram, their colonoscopies, these other things that are the barriers that generally exist, right? If I'm busy using heroin, I don't care about what my next lab draw and my cholesterol says it should be. Again, I care about scoring more heroin. So. We want folks to be employed. We want them to go to school. We want them to do things, and this is really gratifying. When these substances, when you're treating folks, and here's our contact info. But this is an incredible part of medicine where you can take somebody who is truly marginalized. They are, in every sense of the word, can be described as victimized in their engagements in our society. You can get them stable. You can give them a medicine, you can give them hope, and they can go back to school. They can have relationships with their children. Maybe they've lost them to state custody. They can re-engage with their former spouse. They can re-engage with their parents. Again, you can see a really dramatic shift very, very quickly with some of these patients. And again, with the trauma-informed care approach, with the harm reduction model that we employ, it's not that we're doing this to the patient. We're facilitating their decisions to live the life they want to live. And so that is why we take this approach. And when it works, it is amazing to watch that transition. And again, you can see it week to week. You can see somebody who looks healthier. They're engaged with their community. They're going to school, they've got a job. Again, these are things that are really gratifying that we don't really see, and certainly I don't get a lot of window into looking into what that looks like with my job at First Care. So again, very gratifying, very important part of what we do and one of the services that we offer here at TVC. So this is my business card that I had our case managers take a picture of and blow up. Most important there is our phone or our email address, and I have a slide with that. Here's one of our referral forms. So your doctor, if you see a doctor in TVC or you see a doctor outside TVC or you end up in FMH or a family member does and you think they need our help, this form is available and is another way for your physician to get in touch with us or your PA, whoever you see. And then ultimately, the best way is either send us an email, call that phone number that rings to our case managers who check that phone every day. And most of the patients that we end up seeing in the office just call us and they say, I think I need help, or a family member calls and said, hey, my son needs help, or my spouse needs help, my boyfriend, my girlfriend needs help, and ultimately that's how we address this. So again, I know this is different because I'm talking to an empty room. Normally I would be sitting here and say, who's got questions? Or I normally start off a lecture by saying, hey, I like things to be pretty informal. If I say something that's not clear, or if you have a question, just shoot your hand up and we'll address it right away. Because oftentimes if you say, hold the questions till the end, people forget their questions. But again, I'm glad that I got this opportunity to talk about what I do. I hope it comes through in this video that I'm very passionate about this. The team that I have is amazing, and we're very fortunate to have really gifted and really compassionate case managers. The other docs are phenomenal. Everybody who engages in this kind of medicine is coming at it from a place of caring. And certainly the more we talk about this, the more we offer these services, the less stigma there is and the more likely people are to be successful. So normally I have a big questions at the end slide, but instead I'll conclude with this. Now, I do have one audience member who's working the camera, so maybe questions? Nothing there. Okay, so that's my one attempt to feel back towards more comfortable with talking just into a camera. But I hope that this has been something that's been enjoyable. Certainly reach out. That email address gets checked multiple times every day, and we will get folks the information they need, get them plugged in. Even if it's not getting care with our organization, we'll get you plugged in. Our community focus is that there's no wrong door for treatment. So if that means you go to the ER, but you really need to be with us, perfect. If that means you come to us and you really need to be in the emergency department, we'll send you over there. That's really the way we look at this, is tackling this problem. And the approach of pretending it doesn't exist is not going to get people the help they need. So like I said, one of the reasons I was so excited to make this a priority, even in the middle of the coronavirus response, is this is going to be here. Coronavirus is going to come and go. I promise the opiate crisis will still exist, and I have told many people that I will probably be able to work and keel over dead in an exam room, because I will have a patient who needs my help for many, many years to come. And we hope to be available and be part of that success. So with that, I will wrap it up. And if you have questions, reach out, give us that phone call or that email. And thank you.